So once again, good afternoon and good morning, everyone. Thank you for joining us today. Before we get started, I just have a few housekeeping items that I would like to mention. The slides and recording from today's webinar will be made available and sent to all participants. Closed captions are available during today's session. Just click on the Show Captions button on your main Zoom toolbar. If you experience any technical difficulties, please notify me, Patrick Ahern, in the Q&A section. Questions can be submitted into the Q&A window at any time and will be addressed upon completion of the presentation. With that said, I'll go ahead and turn things over to Sari Schumann to get us started. Thank you.
Great. Thank you so much, Patrick. And thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Lewy Body Dementia, Navigating Diagnosis, Care Strategies, and Essential Support. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. And before we start, Chris Stockton of the Administration for Community Living will provide a brief welcome. Chris?
Yes, thank you, Sari. On behalf of ACL, Helen, and Julia, I would like to thank you for taking time out of your busy days to come and join us for this very important webinar on Lewy body dementia. And Sari, if you'd like to introduce our two speakers.
Sure. Thanks so much, Chris. And as you heard, today's presenters are Julia Wood and Helen Bundy Medsger. Julia Wood is an occupational therapist and international presenter specializing in Parkinson's disease and related dementias. She leads professional and community education at the Lewy Body Dementia Association and serves on multiple advisory boards. Julia also contributes to clinical guidelines and training programs, co-authoring the first AOTA practice guideline for adults with Parkinson's disease and serving as faculty for LSVT BIG and the Parkinson's Foundation Team Training Program. Helen Bundy Medsger is also joining us today. Helen was the care partner and health advocate for 2 generations of her family who lived with Parkinson's disease with Lewy body dementia. Her more than 35 years of experience with the disease includes being a Lewy Body Dementia Association affiliated support group facilitator, educational speaker, and an advocate for and participant in research. Her unwavering commitment to the Lewy body dementia community resulted in her being named to several roles, including being appointed to the U.S. Department of Health and Human Services Advisory Council on Alzheimer's Research, Care, and Services. At this time, I'm going to turn our presentation over to Julia Wood to begin.
Thank you so much, Sari, and thank you so much to ACL and the NADRC for hosting us today, and especially a big thank you to my colleague, Helen Bundy Metzger, and our volunteer. She is a dear friend of this organization, and we're really excited to have her with us. All right, so we're going to talk today about how you can work with the folks in your community and that you service that have Lewy body dementia. So we're going to talk about all of the, I'm going to give you the backdrop on all of the diagnosis. We're going to talk about those core symptoms and diagnostic considerations and how you can really distinguish Lewy body dementia from the other types of dementia that you might see in your practice. We're also going to hopefully help you kind of determine some communication and care strategies that Helen's experiences and the stories that she'll share with you, I think will really help inform to help you have more supportive and so you feel supported and you feel that those you're helping are also supported. And we also hope that you'll be able to evaluate the challenges that are really faced by individuals with Lewy and their families, and then ways to help enhance their care coordination, which can be very complicated, and also resource accessibility. So we'll go ahead and get started here. So I think you're probably all familiar with this concept that dementia is really an umbrella term, but what a lot of people don't understand is how prevalent Lewy body dementia actually is. So you'll notice that we have Alzheimer's disease here, of course, taking up for the majority, and that's what most people are familiar with. In fact, a lot of people really think Alzheimer's equals dementia and aren't aware of these other types, and that's why we really appreciate the work of the NADRC and what you're doing to help people understand that there's these other types of dementia that you may see as well. So Lewy body dementia technically is the second most common progressive dementia, because you'll notice that vascular dementia from those strokes or TIAs is kind of mixed there in the middle, but we think it's about 1.4 million people in the United States are living with Lewy body dementia, and accounts for about 10 to 25% of dementia cases. And then you'll notice frontotemporal dementia, which I think you've had the Association for Frontotemporal Degeneration degeneration come and speak to before, takes up that last 10 to 15%. And so what can be really confusing for people is when we talk about, the name synonymous or that we associate really with Lewy body dementia, there's a lot of things that come up. So really at the top, you'll notice there of our little stack of pyramids is Lewy body disease. And so that is really when we have this misfolded protein present in the brain that is a Lewy body, and the protein is alpha-synuclein. And so you'll notice on the left-hand side there, that accounts for Lewy body dementia. But then you might have seen, is it DLB or LBD? And we're going to clarify that alphabet soup in just a moment. So this can include dementia with Lewy bodies, which you might have heard of, diffuse Lewy body disease, where we see a lot of disease presence in the brain in a much quicker progression. Robin Williams had diffuse Lewy body disease. And then also people can have a mild cognitive impairment with Lewy bodies here. And then on the other side, on the right-hand side of your screen, you notice that there's Parkinson's disease. And so that relationship a lot of times is really misunderstood. And then what's Parkinsonism versus Parkinson's disease? And of course, with Parkinsonism, we're talking more about those movement changes, the stiffness, the slow movement, the tremor possibly, the changes to how they walk and their posture. And of course, we know people with Parkinson's disease, even early on, can have changes to their cognition that might be more subtle, but even into a mild cognitive impairment. And then it's estimated that as the disease goes on, most people, or about half or more of people with Parkinson's disease, will go on to develop Parkinson's disease dementia. So we'll clarify this a little bit more on this next slide here. So I'll introduce you to our umbrella, the Lewy Body Dementia Association here. So Lewy body dementia, when we talk about LBD, it's like a bad equation that it equals both Parkinson's disease dementia and dementia with Lewy bodies. And you'll notice that little image up in the top right-hand corner of your screen, that's a Lewy body. So that's that misfolded clump of protein there blocking up that neuron, and then the cell transmission has difficulty, of course, getting through. So it affects the communication and processing in the brain, and ultimately results in cell death and some progression. And this is the thought that we have at this time about kind of how the disease moves. So you'll notice in the case of Parkinson's disease dementia, this is someone who has established Parkinson's disease, right? They've had it for at least a year, and sometimes maybe that those cognitive changes or the dementia will happen like we talked about, but it's at least a year or more after they've got that established diagnosis of Parkinson's disease. In the case of dementia with Lewy bodies, on the right-hand side of your screen, the dementia comes first. So a lot of times they're going to have the cognitive changes that impact that ability to do daily tasks prior to or at the same time, or even within a year of their Parkinsonism onsetting there. So we'll see that the cognition really happens first. And for some folks with dementia with Lewy bodies, kind of rare, they may not have many of those movement changes or that Parkinsonism at all. There'll be more of a cognitive presentation. So you can think of it kind of like a chicken or egg. If the Parkinson's comes first, those movement changes, it's Parkinson's disease dementia. The dementia comes first, dementia with Lewy bodies. But either way, they're both types of Lewy body dementia because they have these protein bodies, these misfolded clumps of that protein in the brain. So how is this diagnosed? Well, this gets a little bit tricky, right? So they have to have dementia, which is just that cognitive impairment, right? That's a significant enough to impact daily function, plus 2 or more of these core clinical features you'll notice here at the top. So spontaneous Parkinsonism, so that slowness, stiffness, those changes to movement. REM sleep behavior disorder is very common, and sometimes 20 years or more prior to the onset or the symptoms really of Lewy body dementia. This is where somebody may really act out their dreams physically in the night. We also see fluctuating cognition, and I'm going to talk more about this, but 1 minute they might seem really wide awake and alert and responsive, and the next minute really zoned out. And then another common feature is these fully formed visual hallucinations. And so if they have dementia plus 2 of these features, then they can be diagnosed as clinically probable, because we still don't really have a test yet, right? That definitely is going to give people this diagnosis. But then you'll notice at the bottom, another way it might be diagnosed less commonly here is that they have dementia plus one of these core clinical features that we talked about at the top, plus one of these indicative or testing features here. So a DAT scan can show dopamine uptake in the brain. So if they get a positive DAT scan, that could be helped to inform the diagnosis. A sleep study there in the middle where they're looking for that REM sleep behavior disorder. And then also a heart test here, the MIBG. So those can be used along with one of those core clinical features in the dementia to make that diagnosis. So, what does this look like though in real time, right? We kind of went through the ideal situation of how it's diagnosed. It's underrecognized and underdiagnosed. In fact, I promise you, there are some of you out there right now thinking, as we start going through these symptoms, Mr. So-and-so or Mrs. Jones, I think really might be in this camp. Because on average, it takes 18 months, research suggests, and 3 doctors to get a correct diagnosis. So this is something where if you have someone, a family that you're helping, and you're like, I'm not sure they've been diagnosed with Alzheimer's, but I don't know about that. You might want to get another opinion here. They might need to see a neurologist, a movement disorder specialist, a cognitive neurologist, a geriatric psychiatrist, a neuropsychologist. We'll talk more about those as Helen tells her stories, but it may take more than just that one visit. It's important to note it's not just the most often misdiagnosed form, but it's the most expensive form of dementia. And we'll get into that a little bit as we talk about the complexity of the symptoms. So then what about Parkinson's disease dementia? Well, right, these folks already have established Parkinson's disease typically, right, and those motor changes, but this is where you guys can really step in. It's so important to screen and monitor for cognitive changes for people with Parkinson's disease. Like I said, early on, they could have changes to, doing complex tasks, bill pay, driving. I mean, it could just be mild. But as it goes on, they can develop that dementia. And we really want to make sure we keep an eye on this. It can mask and hide a lot more. You'll notice there's that statistic I talked about earlier. The higher end, it's estimated up to 80% of people with Parkinson's develop dementia. And you'll notice that's a 4 to 6 times higher risk than for people without Parkinson's disease. And important to note too, like I said, even if you have someone in your care who's maybe struggling cognitively, it could just be a mild cognitive impairment, very common with Parkinson's. But I think this is where it's important to, when you're supporting those families, to make sure they're looking not just at those movement symptoms, but those changes to cognition as well. And so, how does it differ from Alzheimer's? I think this is something I really like to help people understand because most of you probably have a good understanding. With Alzheimer's, we're thinking more memory problems, difficulty forming new memories or taking in new information. The physical symptoms, if they happen, will happen at later stages. And you'll notice that's kind of the opposite with LBD on the other side here. Memory is really more spared in the beginning and really related more to changes in attention. The fluctuations and their ability to think and remember can really be confusing to people because one minute they'll seem spot on, the next minute they're zoned out. You're going to see more issues with problem solving, attention, and reasoning. And the physical symptoms, that Parkinsonism, maybe changes to how they're walking and moving, can be present at all stages. And we also know that those hallucinations, right, and those changes to their sleep can be present early on. So now when we look at the initial cognitive complaints, if you've got someone that's maybe just starting to have changes with Alzheimer's, you're going to notice more things where they're not retaining information. And you maybe feel like you've had that conversation and over, and they repeat comments and questions within that same conversation. But then when we compare that to folks with Lewy body dementia, we're really seeing more changes to that processing speed. Not only does their movement get slower, but their thinking gets slower. They can lose their train of thought. They have more difficulty multitasking and keeping track of more than one task at a time. And another one that's really, really unique, I think, to Lewy is these changes to their visual perception and their spatial skills. So they have trouble seeing. They can't find their cell phone lying on the counter, but the optometrist said that they have 20/20 vision. They might have trouble finding, an item in their bathroom that's busy or cluttered. And they can have difficulty with things they've done in the past, maybe hobbies or tasks that rely on vision, like repairs, doing hobbies or assembling. So this is something we really need to keep an eye out on. And you'll notice here, I love this graph because I think it really shows you the difference. You'll notice here, these were neuropsychiatric measures, these different bars here that people did to test different domains of cognition in Alzheimer's disease, here at the top set of graphs, and on the bottom, dementia with Lewy bodies. You'll notice there, those red bars, they were testing memory, green bars were language, yellow, we've got attention and executive function, and blue is visuospatial. But what I want to call your attention to start is that black bar on the far left. That's the dementia rating scale. Global measure, right, of cognition. Notice how that's exactly the same. And that's where the similarity ends. When we start looking at memory on the bottom, those folks with Lewy scores are high, the top, Alzheimer's very low. Look through those and see, with Alzheimer's, we're looking more at memory changes, language changes. And with our folks with Lewy, we're seeing more with their attention and executive function, their visuospatial function. Why I love to share this slide. That's why if you don't get past just a basic global rating like a MoCA or a mini mental status examination, you may not know whether they have Alzheimer's or Lewy body dementia. So this is where having them screened by a neuropsychologist or doing a little bit deeper dive into their cognitive symptoms is important. So those fluctuations, those cognitive fluctuations that I mentioned earlier, where their attention can really vary, this can also look like delirium. So it can vary within the hour, from day to day, hour to hour, and this can be confusing to both family caregivers and even paid caregivers where, well, Mr. Jones could put his shirt on yesterday, he didn't have a problem, or oh, they're faking it. They could do that, this morning. Not necessarily. So the level of consciousness, you notice their speech, their attention can really wax and wane throughout the day. So this is a key part of education for families, for paid caregivers, for really that level of understanding for folks with Lewy body dementia. And so we talked about diagnosis and kind of what it looks like and how to spot it. But as you can imagine, managing it is no cakewalk. So we've got all of these different symptoms here in our Venn diagram. And what this is really meant to represent too is how it's not just the cognitive changes. It's not just the sleep changes we've talked about. They can have autonomic symptoms where their blood pressure can drop dramatically, changes to bowel and bladder function. We may see changes to sensory. So the vision we talked about a little bit, but sometimes they can have different pain or sensations as well. Motor. So we talked about that Parkinsonism, and that can impact falls and safety and balance. And then the elephant in the room always are the neuropsychiatric symptoms, the hallucinations, the delusions, the mood changes like anxiety, depression, and apathy. And what's so hard for families and for clinicians is these don't happen in a silo or a vacuum. They're interacting and acting interdimensionally as well. So the neuropsychiatric symptoms, it's important to note, these happen earlier and more frequently in Lewy compared to other neurodegenerative diseases. And I kind of called these out. I didn't mention agitation, but that can also be a problem. And important to note that a lot of times behavioral disturbances can be one of the most problematic issues for both clinicians and for families to deal with. And it's estimated that 40 to 60% of individuals with LBD have these behavioral issues as well. So with all of this, right, when you think about all of these symptoms, the changes to cognition, we see an increased need for help. So we did the survey actually at the Lewy Body Dementia Association here, where we surveyed LBD care partners, and they reported increasing dependence of the person with Lewy for both their basic activities of daily living, like showering, bathing, grooming, but also a lot of times those things like bill pay, doing tasks at work, maybe home management tasks. And then when we look at those complex tasks that a lot of people need to do, especially if they live alone, right? Shopping and cooking, over 90% of people with LBD were unable to perform or needed some substantial assistance. And then even for those basic ADLs like dressing and bathing, you'll notice here that over 60% of our respondents reported that the person could not perform these activities at all. And then driving is really important to keep an eye on because the visuospatial deficits, even some of the hallucinations or cognitive fluctuations, can really impact safety with driving. And then I talked a little bit about those motor changes. We see a lot of issues where this can impact falls risk. So getting our physical therapy colleagues in there, occupational therapy colleagues can be so important because the onset of these recurrent falls is much shorter for folks with dementia with Lewy bodies, even than for people with Parkinson's, who we know are at a higher risk for falls. And then there's a far greater risk for falls and also a shortened time period between the time that they're diagnosed for people to start to have those recurrent falls when we look at folks with dementia with Lewy bodies versus Alzheimer's. So this is a big safety thing to keep your eye on. Also, for those folks with both Parkinson's disease, dementia, and dementia with Lewy bodies, they have increased falls risk. So home safety evaluations and things like this become really important. And this will show up when their gait and balance measures are tested. And this, can be in comparison with those with Alzheimer's. We're going to see this more. So this is why we want to get their gait and their balance assessed by our physical therapist with familiarity with these conditions. And then when you see that more severe Parkinsonism, so the slowness, the stiffness, the tremor, that's associated more often with those falls than for people that maybe have less of those movement changes. And then, as I mentioned, those abnormalities in gait and balance really correlate with the increasing falls risk. And it's important to note that most of those tests and measures are only accurate in predicting falls for about 6 months. So not only do they need to see physical and occupational therapy, but usually at minimum twice a year, so we can really keep an eye on that falls risk. So the current treatment strategy is really to improve quality of life. And I think you're going to hear from Helen all the things that she did to really work on that. And, many of these symptoms can be managed or reduced with medications and also other therapies like we've talked about. But unfortunately, at this time, there are no treatments that are available to stop the disease progression or to really treat the disease in some way. And it's important to note when we start to treat those different symptoms that they can have a lot of medication sensitivities. And so many of those traditional antipsychotic medications like haloperidol block dopamine and can literally be deadly for somebody with Parkinson's or with Lewy body dementia. So we want to really think about that care team being informed and understanding that as we're trying to manage that agitation or hallucinations or delusions, we're going to have to be really careful. And then some of these medications can cause this neuroleptic malignant syndrome. And so this can cause severe fever, muscle rigidity, breakdowns. We want to make sure if any of your folks with Lewy maybe start a new antipsychotic and start to have some weird symptoms, we want to report that back to the care team and check in and make sure that they're not having a severe reaction. And unfortunately, even benzodiazepines can lead to increased anxiety or worsen cognition. So sometimes in trying to treat mood, things that they can actually make it worse as well. And even over-the-counter medication. So taking something as simple as an allergy medication can cause complications. So I encourage you, if you have families, making them aware of this, tracking any symptoms or side effects if they start a new medication can be such an important strategy to teach your families. And of course, other helpful interventions I've kind of alluded to here, nursing, PT, I gave a big shout out to. I really think it's important you find good clinicians and get someone on a regular plan of care. Occupational therapy, that was my role prior to being at the Lewy Body Dementia Association. I worked at a center for excellence and worked with these families. So much work I did on not just preserving their independence and autonomy and agency as much as possible, but also their safety and mobility. Speech therapy can help a lot with some of the cognitive linguistic challenges that they have around language and word finding, as well as swallowing difficulties that can also be a problem. And then, as you can imagine, with all of these different changes and disruptions to the family, getting access to social work or possibly counseling can be really helpful for the family as a unit. And so with that, I'm going to turn it over so you can really learn, I think, the most useful nuggets of the day, which is a family's journey, what that really looks like, as told by my dear friend, Helen Bundy Medsger.
Oops, let's go backwards. Thank you. Hi. I don't know if you can see me. I hope so. Thank you, Julia. Good day, everyone. I'm Helen Medsger, and today I'm going to share my family's journey and walk you through some of the challenges I personally experienced and the lessons that I've learned over the many years. Then I'm going to provide you with some strategies for supporting and caring for a person living with this disease and for yourself. Next. Knowing that Lewy body, with that Venn diagram you saw, affects 6 different clinical domains, presenting more challenging symptoms than many other dementias. I always tell the caregivers that I work with, I view caregiving as a journey, one that is not a sprint, but a marathon being run over incredibly challenging terrain through threatening clouds and violent storms. But if you keep putting one foot in front of the other, seeking help along the way, you'll find days when the sun comes out. It's not an easy path, but if you prepare yourself, learn new strategies, and ask for support, there will be moments of light. Next. I'm going to introduce you here to my 3 family members who lived with LBD. We start with my father, who in his medical record exhibited cognitive difficulties and Parkinsonism in the late 1980s. He was subsequently diagnosed with what we term an unusual phenotype of Parkinson's disease. And the reason for that was because the diagnostic criteria for Lewy body dementia was not published yet. It wasn't published until 1996. My sister and youngest brother were each diagnosed with young onset dementia with Lewy bodies. She was 52 when her clinical symptoms broke through, and my brother was only 49. Next slide. First click. My father was first diagnosed with organic brain disease. Now, that's an older term that was used to describe all neurocognitive disorders, including dementia. Then it was Parkinson's disease while he was also experiencing profound hallucinations. Later, due to a severe medication reaction, he had a severe psychotic break that required an inpatient psychiatric evaluation, resulting, sadly, in us being told that he could never return home. So he went into a long-term care facility where he remained until he passed away. Next. Now, my sister lost her sense of smell when she was only 35 years old. And then at 52, we saw a breakthrough of her first clinical symptoms. What I really love is they were initially completely diagnosed, right? She was a woman. They said, oh, menopause. Women experience memory loss during their menopause. So then it was depression because she had a flat affect, right? That flat face, lack of expression we may see. And so off to the psychiatrist she goes. But then it was finally Parkinson's. When her autonomic system dysregulation was discovered, though, it was very, very severe. So they took it to another synucleopathy. Oh, she's got multiple system atrophy. But because the problem being my sister was very intelligent, well educated, and very articulate, so the clinicians dismissed her complaints about having cognitive problems. It took 5 years of requesting and seeing multiple specialists before she was able to obtain a neuropsychological evaluation, which detailed her profound deficits. Then my brother. My brother had severe REM sleep behavior disorder while he was in his 30s. Less than 20 years later, he was diagnosed with Parkinson's, then within a year, dementia. Next slide. But what were the impacts that I had to learn to navigate? With my father and sister, I was directly impacted as I was their primary care provider, and I was their advocate and power of attorney. Now, with my brother, it involved just helping he and his wife remotely. So with Dad, I witnessed and contended with his confusion and terror while in psychotic episodes. With no advanced planning in place, I had to battle the financial and legal systems to address he and my mother's needs. I had to advocate for minimal medications due to his severe drug reactions. and sacrifice his mobility for his mental well-being. With their limited assets, how were we going to pay for care that was being mandated? Well, I had to budget what little money they had left and then qualify him for Medicaid. And the most challenging in all of this, in his final year of life, I worked with a county patients' rights advocate, also known as an ombudsman, to document and report the neglect that he suffered, resulting in the facility being charged with 16 deficiencies in his care. Now, with my sister, it was very different. I was stepping into being her primary care partner, but I also had to learn how to respect her family's dynamics. I had to seek out and apply for all of the various benefits that she was eligible for, whether it was her former employer or the government. And I had to negotiate how the family was going to budget and pay for her care costs over many years. But there were positives, there really were. There were positives that were sparked by her neurologist. His advice: keep her physically and socially engaged. So we adopted that philosophy as one of the pillars of her care plan. We enrolled in research studies and we sought as much support as possible. Now, my brother was a completely different story. He and his wife lived across the country and preferred not to keep us informed or involved. They had no medical insurance, so I worked with them to get him enrolled in research so at least medical professionals were following him. Then, given the fact that our mother, her roots, I supported his application for dual citizenship so he was able to obtain medical coverage out of country. But that required a 16-hour drive each way for as long, and that only lasted for as long as he was able. Next slide, please. Now, I've shown you 3 individuals, all with unique challenges. But what I've learned is, after more than the 5 years of crisis management through my father's journey, I learned I had to do things differently moving forward. I was only in my mid-30s when my dad got ill. And when it became acute, and then those 5 years till he passed, I was emotionally and physically spent. I nearly broke. I still had my own family. I had a career, and I had the care of my mother, who was brain damaged when I was 11 years old. So I knew moving forward, I couldn't do this again. Unless I attacked things differently, it was absolutely necessary that I make changes if I was going to be able to support my sister and be able to maintain my own health. So how did I strengthen my ability to cope? Well, first, I gained knowledge. I sat with my sister and we had these really intimate and deep conversations. What do you value? What are your goals, not only for your health and your care plan and your future, but what about your goals for your children and your husband, your family in general? We discussed the financial and legal concerns, and I did the deep dive so I could be informed before addressing them with her family. And unlike before, I took the time to find out what support was available to us. Next. Next, I educated myself. Lewy body dementia was still not widely known in the general public or understood at the time, but I combed websites of the leading medical and research institutions throughout this country and globally, attended conferences and viewed webinars. I connected with the Lewy Body Dementia Association and its caregiver support forums, and I found an LBDA affiliated local support group. And much to my surprise, the more we became involved in research studies, that provided an avenue for us to stay abreast of the latest science, treatments, and management strategies. Next slide. But it didn't end there. I had to get my act together. If I was going to be able to stay on top of my own responsibilities and family, I had to organize the piles of information and documents that her care required. I went old school at the time. I put together an emergency binder that was kept up to date with all the items listed here on these slides. And mind you, you will get a copy of these slides. Copies I also provided to each of the other healthcare agents listed in her advance directives. If ever I was not able to respond, they could step in and have all the information handy. Now, in today's world, this information can be uploaded in many cases to the patient's portal or to caregiving apps, allowing that information and documents to be more centralized and easily accessible by authorized individuals. Next slide. But the largest of the lessons I learned that I couldn't do this alone. I needed the knowledge, the skills, and the support of connections. And I always called it, I created a village of care, not just for her, but for me. So the other lesson I learned and what other caregivers have told me, I learned to say yes when people offered help while also learning how to ask for it. We included all the medical providers, the legal and financial professionals, her family, friends, and even her neighbors who provided transportation. And most importantly, I made certain that my own and her mental health needs were addressed by licensed therapists. Finally, when the time was right, respite care, so that she could stay active and engaged, and I could trust that she was in safe hands. Next slide. And this one, to all the care partners, caregivers out there, self-care. Mind you, I'm not the best at it still to this day. It is a process and work. So keep at it. You can do it. As I mentioned, I did participate in professional counseling for several years. I exercised, but I admit that I didn't take enough rest periods, and I still don't. The hard one, practice forgiveness. And I direct this towards those family and friends who don't show up, right? That kind of disappear in this journey, or those that offer unsolicited advice on what you should be doing better when they really don't have a clue about what you're going through on a daily basis. I highlight this because you waste emotional energy being distressed and angry. Forgiveness is truly a gift to yourself. Next slide. So after all my years of struggling through these hard lessons, when I finally learned how to address the needs of my care recipient and my own, along with tapping into what was available out there through information, resources, support, and nurturing connections, I developed the ability to provide proactive versus reactive care. Next slide. This slide, I really love this quote. This slide really spells it out. It's Amy Goyer's definition of a family caregiver, citing the many roles, but pointing out the most important of all, our role as an advocate. My roles have been many, including caregiver to my father, because he suffered without having any insight into his symptoms, to my sister, who had extensive insight. So I was her care partner. We were equal in decision making for a very long time. I became an advocate on multiple fronts, a research partner by enrolling jointly or providing access for my sister. And that is something I still do to this day. I participate in 4 to 5 studies a year. But my most significant were being her confidant and then shepherding both my father and sister through their end-of-life transitions. Next slide. Now I'd like to share some additional insights. I'm going to go through these. Slow down when speaking. They have difficulty. Their processing speed has slowed. So slow down and shorten phrases. Next, calm down. Stress enters the room long before you even do, and it speaks louder than words. Do not overstimulate them in loud or crowded environments. That processing speed starts overfiring. They can't do it. And if you are in a crowded, let's say a family reunion, make sure that there's a quiet space for them to escape for a short while and then see if they can re-enter. Next, act with patience and compassion. Try not to overexert yourself and inject yourself. Be slow and methodical. Next, put yourself into their world. Try to understand what they're going through. Next, and this, always validate the emotion. If they're fearful, say, oh my gosh, I can understand if I was experiencing the same thing you are, I'd be scared too. Help them to always feel safe. You want to be their safety mechanism and always remind them of that. Always ask permission. Don't just force yourself into their world, whether it's real or imaginary. Help them to engage in useful, purposeful activities. Don't overrun it or force it. Let them exhibit what they are able. Always laugh with them, enjoy humor, but not at them. Then remember to breathe and step away. I always tell my caregivers 10 seconds out in the hallway, then re-enter. Next, and exercise empathy by listening not only to what they're saying, but what their bodies and their facial expression are telling you. Next slide. And I'm going to show you how I applied these, first with my father. Next, Daddy said, oh, you came to see the little people with me. And how did I deal with it? I did, Daddy. Come sit with me and tell me about them. Next. This one, my least favorite. I walked into a dental appointment at my father's care home and found a male nurse trying to pry his mouth open. I calmly approached and said, Daddy, this is Doctor. He's a dentist. Please open your mouth. And he did. Next. You can't take my clothes off. My father had soiled himself and required a shower. So I needed to respect his modesty and self. I respect that, but you need a shower, so let's leave your boxers on. Next, my sister. How did we do it? I still want to contribute to my organizations. She was an executive director and had helped found other organizations. So what did we do? We took her to meetings and we took notes and made certain that whatever wishes she had to convey to others, that was done. Next, staff at her care home. She thinks I'm attacking her. She's screaming at me. Are you hot? Yes. The ANS was misfiring. That autonomic nervous system cool her down. Next, best advice, keep her physically and socially engaged. We exercised. We made certain her friends got her to church, and we took her to as many of the intimate social events we could. Next slide. So these are suggestions from the Lewy Body Dementia Association on how to keep people engaged in meaningful activities. Activities should be all about what the person wants, and we can go through this. I know we want to get to Q&A, so you will get these slides, so you'll learn how to step through, how to take the steps to match their ability at a particular moment in time and engage them. Next slide. And what I'd like to conclude with are these following take-home points. Remember, an accurate diagnosis will provide clarity and help not only you, but the medical professionals to provide better and managed care. Create a care plan that not only involves medications, but includes strategies to deal with symptoms outside of medications. Remember, Lewy is unique. It isn't Alzheimer's and frequently requires different management. Remember that village of care I spoke about? Next. Help. It includes a care team that should be designed to meet your person's unique needs. Educate yourself. the person living with the disease, if possible, include them in that education. And then include those members of your village who need further information on the disease and its management. And with safety in mind, encourage physical and mental activities. And the next slide, I want to thank you for listening today. And now I'm going to have others join me back in the room. There is an appendix that we will be posting up. Those people that will be receiving the slides will see all of the resources that the Lewy Body Dementia Association would like you to be aware of.
Great. Thank you so much, Julia and Helen, for your wonderful presentations today. We have a lot of questions lined up. So I'm going to just jump right in. We have about 14 minutes. Can you explain a little more about what a fully formed hallucination is for people so they understand?
Do you want me to take that, Helen?
Go
I mean, I
ahead.
know
Yeah.
you know.
Do I know it? Yes.
So it's important to
Mhm.
know. So when we're talking about the diagnosis, that's where those fully formed visual hallucinations come in. And so it's usually of a person or an animal. The most common ones that you hear a lot of times are children, sometimes little people, sometimes a former cat or pet or an animal. But I want to note that's when we're looking at the diagnosis, but they can also have auditory hallucinations, tactile hallucinations.
Yeah.
All of the senses can be involved. Taste, they can think they smell something terrible or taste something terrible. And what can be really confusing sometimes too is there's some research that suggests that often auditory hallucinations will come in like a soundtrack to the visual hallucination. So now the little person or the child that you're seeing is talking to you, or the cat's meowing, which then really solidifies, right? And kind of validates that more for that person that what they're seeing is real. So, yeah. Anything you want to add to that, Helen?
You know, it's always been interesting to me because a lot of my caregivers, we just did a session on neuropsychiatric symptoms, both the LBDA and then I did with one within my group. And they said, well, the problem is the poor person becomes somewhat agitated because then that fully formed hallucination doesn't respond to them,
Yes.
right? And that is very challenging to be able to contend with. Yeah.
Absolutely. Good point. Good point.
For sure. Okay, we have a few questions about a few other questions about behavioral issues. Can you talk a little bit about some of the most common behavioral issues in a little more detail so people can understand what they might be seeing?
You want me to give an overview, Helen, and then you can
You
jump
know,
in, or what do you
yeah,
think?
I think what I'm going to do is I'm going to jump into one that we don't always think about, and that has to do with the REM behavior disorder. There are many caregivers I work with. What happens is right, this is their dream state, and a lot of times it can be very threatening and fearful. And what happens is they're acting out those dreams. I've had caregivers wake up with their loved one assaulting them. And what occurs is that person may still be in the dream and or they could wake up, but the dream tends to come into their wake state. And trying to bring that back down can be quite challenging.
It's a really
Yeah.
good point to bring up. And I think in general, something to know about the behavioral symptoms that we see quite commonly is they tend to be paranoid in nature. So a lot of the delusions and hallucinations that we see, like for example, one that's really common is Othello syndrome. So the person will think that their loved one is having an affair, right? And as the care partner, you're like, with what time? Like I barely have time to take a shower, and now you think I'm having an affair with someone. Phantom boarder is another one. I think that someone is living in their house. We've heard these mix up where we had someone call into the Lewy line and they thought that their spouse was having an affair with the man who lived inside the couch. So a little bit of Othello, a little bit of phantom boarder.
Right.
Also, with some of the visual issues that I mentioned earlier and that Helen talked about, we'll see misidentification syndrome. So Capgras delusion or Capgras, depending on who you're talking about. So the person may think that you're an imposter. And so they'll think, and what's really interesting, like I had a woman one time, she'd been married to her husband for almost 40 years. I'd known her for 2. she thought he was an imposter and wouldn't let him in the car, but would let me in the car. And so this can be really tricky for people to navigate and to understand, because they're a lot of times very, paranoid and kind of attacking and personal. Maybe someone's stealing their money or taking their things, and you've always had a positive relationship maybe with that parent or your spouse. So really, really hard. Very challenging.
Thank you for explaining that a little bit more, and thank you for explaining the REM sleep disorder. There were a few questions about that. So we'll move on to, I've seen 3 or 4 questions at this point come through about asking if Lewy body dementia is known or proven to run in families, be hereditary, have some kind of genetic component, just based on what they heard from you, Helen, and just other people have commented that, they have a brother and a sister. So if you could comment on that, that would be very helpful.
Okay. Julia, do you want to hand this? I mean, I know the scientific end too, but in the statistics are, at least what the scientists put out there, what is it? They figure 10 to 15% may in fact be genetic. And the reality with genetics is they are looking at 2 different levels, right? They are looking at a fully formed, a highly penetrant mutation, and that would fall under what we call the SNCA. And so that's the gene that deals with alpha-synuclein. But there are others, and we can have a whole variety of what we term genetic code variants. And that will fall under a variety of others. The one that's most recently, in the last 10 years, being looked at is the GBA. And to be candid, yes, I'm one of the family that has variants, but I'm rare. And so it's we just keep pushing forward and keep ourselves healthy and exercise and eat right, and keeping socially and mentally and physically engaged is important to keep it at bay.
Absolutely.
So, anything you want to add, Julia?
No, I think she was perfect. And, just keep in mind, I think this is an area that we're still continuing to learn about. And there's a lot of research going on in this arena. This is why, the Michael J. Fox Foundation is doing some incredible research this way. I encourage you, if you have family members with this, to consider, participating in research, because we really do need that data to understand better how we're seeing some of these family patterns.
So can you just expand on that a little bit? There was a question that came in about, I have 2 questions right now. One is, someone was asking how you get involved in research. So you just mentioned the Michael J. Fox Foundation, but how great that people want to be involved in research. So let's share maybe where people can find those connections, and then I'll get to the next question.
Okay. Well, there's a few ways to do it. Number one, the Lewy Body Dementia Association has what we call the Lewy Trial Tracker. They just have to go to the website and look it up, search Lewy Trial Tracker. You can register there. And so they will, curate specific studies that you can get involved in. The one that I started out with and still utilize frequently is the government site, clinicaltrials.gov. You can put in keywords, search words, and find just a huge plethora. You can even put in symptoms. It doesn't matter whether you're a person living with the disease or if you're a care partner. There are a broad spectrum of research studies. Like I said, I participate in 4 to 5 a year, and 2 to 3 of them that I participate are every year I go in, and it will be from till I'm gone. They will follow me. So there's something for everyone out there in research.
I did want to give a shout out really quickly to the Persevere study that is currently recruiting at Rush University. And this might really be a great resource for this audience. So Persevere is a study looking at a peer mentoring program for care partners, completely free. And so they match a care partner who is in need of support with a mentor who's been a former care partner or maybe current, is feeling more on top of their game, education, resources, support. It's kind of like a buddy system. This has been a really popular study, and you can find that on our website. So it's Persevere, or on Rush University as well.
Yeah. I was part of their second phase. It is a fabulous, fabulous study.
Great, thank you. So given that we have a lot of practitioners in the virtual room, can you talk a little bit about, and care partners and caregivers, can you talk a little bit about some strategies that people can use to work through some of the symptoms of LBD in a little more detail in 5 minutes?
In 5 minutes. Yeah, I normally do an hour talk on this.
Yeah.
Yeah, Julia, let me take ANS, the autonomic symptoms. Certainly behavioral tends to take the oxygen out of the room, but the reality is the precipitation of falls, reactions, agitation, confusion can all be dealt, within the realm of the autonomic nervous system. And many times, and no offense, clinicians, you're not told about those symptoms until they've had a major fall or they're experiencing secondary symptoms. So things like heat dysregulation because their thermoregulatory system has gone awry. Their blood pressure is all over the place, normally dropping, and then they drop. Increased confusion with regards to that. It covers so much because it controls all organ function. And so those are things that I encourage clinicians to put forth first so that caregivers become very aware of why those things are occurring and kind of be proactive and say, oh, maybe I need to watch that blood pressure, or maybe I need to cool the room down so that they're not internally, burning up. So that's my 2 cents worth. Yeah.
Absolutely. And then I'll kind of quickly touch on, we have a full webinar, I think from 2023 on cognitive strategies. I did one recently on neuropsych symptoms, on vision. So I encourage you to go to our LBDA a YouTube channel called LBDA TV, and you can see recordings there. But definitely when we're talking about cognition and or vision, thinking about the environment that the person is in. So it needs to be, think about how their brain is processing that. If there's a lot of clutter, if the light is dim, if there's a lot of distractions, that's going to make it hard not only visually for them to find what they're looking for, but in a cognitive perspective, their brain then has to filter through all of that stimulation. Things like having the television and the radio on in the background when you're trying to have dinner, and then you wonder why they're completely zoned out. So thinking about limiting distractions, keeping the environment more supportive and more calm and more simplified, and then thinking about how you can adjust tasks and really making them more simplified, looking at something one at a time, right? One step at a time rather than the whole task. And so, like I said, we've got some great content. We also have a course on our Lewy Learning Center called Supporting Meaningful Engagement, which really walks through some of the strategies about how to cope with some of these symptoms that we're talking about. So I encourage you to check out for more in-depth information, because that was a quick overview.
Yes, that was quick, but very helpful. Thank you. We have time for you to make some final remarks before we close out. If there's anything you want to add based on what you've seen through the questions that have come through or anything else. To those of you who asked for specific help, I just want to mention, I did send you the phone number for LBDA in your private messages. So please take a look at that. We want to try and get you the help that you need. But Julia or Helen, do you have anything else that you want to add before we close out?
Well, I just want to thank ACL and NADRC for really putting this forth. For the longest time, Lewy body dementia was not acknowledged. It is still not widely understood in the general public, and yet it has such great need. So thank you for that. But Julia and I just am going to put in, our support line is manned by social workers. They are top notch. And you can also, our support group network throughout the country is available to find something local to you on our website.
Absolutely. And I want to thank you, Helen. And once again, thank you all for joining us and for your interest. And please consider the Lewy Body Dementia Association a resource, not just for your families and those who care for, but also for you. If you have questions about how to find resources, symptoms, even if there's certain education or things you want to learn about, you can reach out to our support line. You can email them support@lbda.org, or you can call them at 1-800-539-9767, and they can curate the resources you're looking for, find, answers to the questions that you have. So please consider us, an ally in your corner, because we're here to help.
Great. Thank you so much. And thank you everyone for participating today. If you have questions about the webinar series, you can use the email that appears on your screen right now, nadrc-webinars@rti.org. And then we'll meet again for our next webinar, which is about frontotemporal degeneration on August 12th. If you haven't received your invitation for that yet, an email, you will get one very shortly, or just send us a quick email. I just sent out the website address also for LBDA in the chat. So thank you again, everyone, for attending, and we hope to see you again soon on another webinar. Good afternoon.
Great.
Bye.
Bye.
Thank you.
Thank
Bye.
you.